on today, International Children's Day. Thank you to the INMO for asking me to present today. My name is John Campbell. I'm a clinical nurse specialist in child adolescent mental health, and I work in the mental health liaison team in CHI at Temple Street. So I could talk about self-harm for quite a few hours. It's a topic that's quite interesting to me, but we have a very short amount of time today, so we'll try and give you an overview of this issue among a cohort. So by the end of today's session, you should have a brief overview of self-harm in children and young people in the Irish context. You should know the function of self-harm, and that's really important in children and young people. Understand that self-harm is understood very differently to suicidal ideation. And hopefully you should learn some helpful strategies to work with self-harm, and also be aware of relevant resources about self-harm in children and young people. So a little pop quiz. I don't expect you to answer because I know you are all muted, but what I want you to do is just have a little think yourself about these questions and whether you would answer yes or no. So first one is, self-harm is a mental illness. Self-harm is an attempt of suicide. Cutting is the only form of self-harm. Self-harm is an attention-seeking behavior. People who self-harm don't feel pain. Self-harm is a phase that young people will outgrow. And self-harm is only a problem among children and adolescents. So have a think about that in your head and think about what you would answer. Would you answer yes or no to these various questions? So the first one, self-harm is a mental illness. No, it is not. It is a symptom. It's a coping mechanism. It is not a mental illness. So someone doesn't have self-harm. They are experiencing these thoughts and they are acting upon them. Self-harm is an attempt of suicide. No, that's not correct. And that's a myth. So we understand self-harm very, very differently to suicidal ideation. Sometimes they do kind of cross over a little bit, and we'll talk about that. But no, it is not the same thing. Cutting is the only form of self-harm. No, that's not correct. There are many, many different forms of self-harm, and we'll look at that later on. Self-harm is an attention-seeking behavior. That's not correct. What I would say is I would turn that around. So sometimes we do kind of get caught in that thought that, this young person self-harm, they're attention-seeking, but I would turn that around and think about that the young person's actually seeking attention. They're seeking help. They're letting us know, they're communicating with us in the only way they know how to, that, I'm struggling here, I need some help. People who self-harm don't feel pain. That's not correct. They do feel pain. And sometimes the function behind the self-harm is to feel pain, is to feel some sort of bodily sensation that distracts them from the more uncomfortable sensations and uncomfortable thoughts. So they do feel pain. So be very aware in children's nursing when we're treating self-harm that we would treat it just as we would treat any other wound or ailment, using pain relief if required. Self-harm is a phase that young people will outgrow. No, not true, but they can get past self-harm with the correct support. Self-harm is only a problem among children and adolescents. Again, not true. We see it quite a lot in children and adolescents as a quite common problem that occurs, yes, but it does occur in adults also. But we're in the privileged position that we can work with young people while they're still developing and hopefully support them into adulthood. So in the literature, when you look at self-harm, you'll see all this terminology: deliberate self-harm, self-violence, self-injurious behavior, self-mutilation, non-suicidal self-injury, cutting. When you look at this slide, self-harm looks very, very complicated. But it's not really, not from the pediatric nursing perspective. We like to simplify it a little bit. But the generally accepted term that we use is self-harm. We don't generally tend to use these other terms. These are terms that are used in worldwide literature. And often children's nurses will come up and say these kind of things to me. They're quite afraid of working with self-harm. They're quite, they feel uncontained in themselves when they see a young person that self-harms. It's a very emotive thing for the person. And often we hear things like, you know, what do I say to them? What if I say something wrong? What if I make things worse? You know, what if they just don't want to talk to me? And these are very common thoughts that we have when we work with self-harm. And it's really important that we acknowledge that it is quite an emotive thing for us as practitioners to work with and to own that. So as I said before, this session will use the term self-harm throughout, which is the most widely accepted term. So first of all, what is self-harm? So self-harm is when someone inflicts physical harm on themselves, and often it's done without people knowing. So they often do it in secret. It is a behavior that is often an expression. So that's a very key part. So it's often an expression of the young person's emotional distress, or difficult or painful feelings. So common methods that young people use to self-harm, the most common one is cutting. And then sometimes we see burning, biting or hitting. Sometimes a young person will hit themselves to cause an injury, sometimes pulling out hair or trichomania, scratching or picking at sores. Sometimes a young person who is self-harming, they might pick at their self-harm scars and try and open them up again. So it's quite common. But sometimes it might include behaviors with suicidal intent, for example, an intentional overdose. But again, being very careful that we don't put self-harm and suicide in the one box. They are understood separately. So why are we worried about self-harm? Based on the national statistics for self-harm and the NSRF, between 2007 and 2016, the rates of self-harm increased by 22%, with increases most pronounced for females aged between 10 and 14 years of age. And although suicide following self-harm in children and adolescents is not common, young people who self-harm have a considerably greater risk for suicide than other young people who do not self-harm. Young people with the highest risk for repeated self-harm were 15 to 19-year-old females. And in CHI at Temple Street at the moment, young people who are referred to us for crisis intervention from the emergency department, we've seen an increase of approximately 15% per year based on last year. And it is estimated that approximately 10% of these are referrals due to self-harm. So the reason why we are quite overall worried, so we know self-harm is quite common. We know it's an expression of painful, difficult feelings or a way of coping, but we also know that with every act of self-harm, the risk of completing suicide increases. So then the risk factors, so these are the things that we are most worried about when we see young people who are self-harming. So female gender, so more in the adolescent population, young people who self-harm are mostly female or more commonly female, usually around 14 to 15 years of age. It's quite common in children and young people who have experienced trauma, so like sexual or physical abuse. Often these young people develop self-harming behaviors to cope with difficult feelings. Self-harm by friends or family members. So if there is a past family history of self-harm or an extended history, this young person is predisposed to self-harming behaviors. And then as well, if the young person has friends or knows people who self-harm, sometimes they may inadvertently learn that behavior as a way to cope. Problems related to sexuality. So we know young people who identify as LGBTQ+, are more likely to self-harm, and they're more likely to experience mental health difficulties. Systemic family issues as well is a risk factor. So difficulties within the family for a lot of different reasons. We know that young people aren't able to process this or able to communicate how they're feeling. So sometimes they may use self-harm behaviors. And then social communication difficulties, for example, autistic spectrum disorder. These young people find it very difficult to express how they're feeling, and they may use self-harm behaviors. High levels of depressive or anxiety symptoms as well. In order to cope with these depressive symptoms and anxiety symptoms, they may self-harm. Impulsivity is quite a factor as well. So often when a young person does self-harm, they don't plan to self-harm. They tend to do so impulsively. So a young person who's noted to be more impulsive is someone that we need to work with. Substance misuse as well. So we know that when a young person is taking alcohol or they're using substances, they're more likely to self-harm because they're taking depressants. And then sleep problems as well. Often young people use self-harm as a way to cope with that. So as I was saying before, understanding self-harm and suicidal ideation as separate entities. So we understand that self-harm is a coping mechanism that young people use to regulate their emotions. And then suicidal ideation, on the other hand, is the thought of not wanting to be here, not wanting to be alive, wanting to die. So there's an intent there of not wanting to be here, but sometimes they do overlap slightly. So sometimes you might see young people who are self-harming with the intent of dying or not wanting to be here. But it's very important that we recognize that they are very separate. So not every young person who self-harms is suicidal. Often young people who self-harm do want to be here and they do want help. So a little bit at the self-harm cycle, and this is a way to help us understand what the young person is feeling or what their experience is when they're dealing with self-harm. And this works on a cognitive behavioral therapy model. So the young person is experiencing emotional suffering, so they're in turmoil, they have all these difficult feelings that they can't quite cope with. There's usually maybe a trigger or something there. Maybe they're being bullied at school, maybe they've had a falling out with someone, maybe they've dealt with a very difficult trauma, so they're feeling all this emotional suffering. And as this goes on, this then becomes emotional overload. So all of these feelings come into one, all these difficult thoughts and feelings. Sometimes they experience somatic feelings as well. They actually feel things in their body, in their tummy, in their bones, in their head, and they feel things in their chest and their heart as well. And this pushes the young person into a feeling of panic. So in order to deal with that, often impulsively, they will self-harm in order to try and get themselves out of the panic. So when the young person self-harms, they'll feel a temporary relief. So often young people will describe self-harm as a release or a distraction or a way to make me feel better. So when they self-harm, they get out of this panic and they feel a temporary relief. Unfortunately for the young person, this is often short-lived. It doesn't last very long, maybe 10, 15 minutes. And then a feeling of shame or guilt will come in as well. So they'll often have these difficult feelings of, oh, why did I do that? Now I've got another scar on my arm. My parents would be so disappointed in me. I can't believe I'm so weak, I'm so useless. And then all these feelings of shame and guilt once again move on to emotional suffering, and then on to emotional overload and into panic. So as you can see, the self-harm cycle goes on and on and on until the young person gets help to break the cycle. So looking at this, you can see it's not a very easy behavior to kind of curb out of. So we're going to look today as to how we can best look at that. So self-harm is understood very differently than suicide. And it's a negative coping mechanism that is used to self-regulate emotions. But if we take this coping mechanism away from the young person too abruptly, they may be left without any coping strategy at all. So if we were to look back, if we were to go into this cycle, and if we were to completely remove self-harm and leave nothing there, something has to fill that gap. So if it's not self-harm, it'll be something else, and it'll likely be another negative coping mechanism. So we need to be very mindful. If we just take this away from the young person, they may be left with nothing at all. So that's why we have to work with self-harm, and we never ever work against it. So you can see on your screens a pink elephant. You're probably wondering what this is all about. But this is kind of an idea of what the young person, how they're processing their thoughts self-harm. So if I was to tell you now, don't look at the pink elephant, there is no pink elephant on the screen. Whatever you do, don't even think about the pink elephant. The pink elephant isn't there. What is the first thing you're going to think about? You're going to obviously think about the pink elephant. If you thought about something else, I'd be very, very surprised. But so yeah, often these thoughts are thoughts that don't go away very easily. They stay there, they swirl around in their head. Sometimes, at times, they're stronger than other times as well. So so the whole point of this example is that it's all well and good to tell someone not to self-harm or to not to feel the way they're feeling, but it's not that easy. Often when we do that, the thought is still there. So it's often not helpful to tell a young person to not self-harm, or just do something else, or to get over it, or try your best not to think about it. Often this isn't very helpful for the young person. We need to work with them and with the self-harm behaviors. So you must never remove a young person's negative coping mechanism without trying to replace it with a different and more positive coping mechanism. So positive coping mechanisms that we might see in the pediatric hospital setting. So in most of in all the CHI hospitals, there's play therapy or play specialists. So we know that it's used in children's nursing to normalize the hospital setting. But in this context, it also provides the young person with age-appropriate distraction from difficult emotions. So the play therapists and the play specialists are really good at providing distraction and routine and structure for young people to keep them busy, because you can imagine that if the young person is hospitalized and they're sitting there with nothing to do, all they have is to sit with their thoughts of self-harm. That can be quite distressing and lead to emotional overload. So play therapy and play specialists are very useful in the pediatric hospital setting. Hospital school as well. It provides structure and a routine to the young person's day, which is really, really important. Visiting as well. So this allows the child to continue engaging with their parents, and therefore enforces the parents as their stable base. So young people who self-harm always have one good adult, so it being mum or dad, or a granny or granddad, or an aunt or an uncle, depending on the family structure. So it's really important that we keep enforcing that one good adult as well while they're in the hospital. One-to-one observation is an intervention that's also used. So when prescribed, it can mitigate the risk of further self-harm episodes and allow the young person to build rapport and drain difficult emotions at the bedside, which is really, really useful. Therapeutic leave is used as well when appropriate, and it forms an essential part of the discharge planning and allows the young person and their family to use positive coping mechanisms at home prior to discharge. So we're always testing. And then, of course, ongoing mental health liaison within the pediatric hospital. So countertransference, really important that we understand this and that we acknowledge this as well, because we all experience it. There isn't a person that doesn't experience countertransference, and we shouldn't feel bad about it, but we should acknowledge it and take care. So it's inadvertently putting our own feelings onto the young person. So we need to acknowledge that and be aware of our own beliefs and values and how this might impose on our patients. So we always must give non-judgmental care and always express unconditional positive regard when we're working with a young person who self-harms, and don't impose our beliefs and values onto them. We must never transfer feelings of guilt or shame onto the young person. We shouldn't have self-harmed, and look what you've done now. Now you don't get to go on leave. Now you don't get to be discharged, because the young person's already feeling these feelings of guilt and shame. So sometimes they're used for the intention to make the young person not self-harm, but often it just makes things worse and they may self-harm again. So responding in ways like this, or to transfer feelings onto the young person, might make them feel uncontained. So working directly with a young person who has self-harmed. So not entirely common. Often when a young person is in hospital, they feel quite safe. But sometimes you may come across an event where a young person might self-harm in hospital. So when this happens, first and foremost, and I always do it as well, take a big deep breath and don't panic. So we always must remember that we need to contain. The young person must feel contained, just like the toddler who falls off their bike and scrapes their knee and the bike is mangled and broken. We're not going to lie down and cry with the child. We're not going to panic and shout and all that sort of stuff. We're going to contain them. We're going to contain their distress. We're going to react appropriately and calmly. We always must remember that self-harm is a way of dealing with and or communicating difficult feelings. So always think about, what is the young person trying to tell you when they're self-harming? Respond using an empathic approach. So I'm so sorry you're having a hard time right now. I can see things are really, really difficult at the moment. Please tell me how I can best help. So treat the injuries as well. If appropriate, help the young person treat their own injuries under supervision. So sometimes children who repeatedly self-harm, often they are empowered to treat their own injuries if it's appropriate. A medical review, a psych review, and an incident report is very important in the pediatric setting. And at the next available opportunity, we should always return the young person back to their normal routine or normal program as soon as possible.
John, I'll have to ask you to conclude, just in the interest of time, that we don't overrun.
Apologies. Sorry, I've minimized your screen, so I probably didn't see you wave. But yes, so this is the last slide now. So basically, we always look at crisis as an opportunity. So it's important to look at every episode of self-harm as an opportunity to help. We always ask what the young person is telling us. How can we best help them? How can the young person help themselves? What can the young person do to help themselves? And how can parents help? How are they reacting? And how can we best keep them safe? And how can parents best keep them safe? So here's a list of resources about self-harm. They'll be on the slides. Please look them up. They've got some really good stuff working with people with self-harm. And also, if you have any questions, you can contact me at Temple Street.